We're going to dive into a really tough question today, something that sits at the very heart of mental health care. What happens when the one thing that's supposed to heal you actually ends up causing more harm?
Yeah, seriously. We're going to unpack how a huge misunderstanding of dissociative identity disorder can lead well-meaning therapists to, believe it or not, reenact the very same kind of abuse their patients survived in the first place, all while thinking they're providing treatment. Okay, so first things first, let's make sure we're all starting from the same place. Dissociative Identity Disorder, or DID. It's not some kind of personality flaw, you know? It's actually a really clever, though very complex survival strategy. When a mind is faced with trauma that is just too much to bear, it compartmentalizes, it builds walls, it creates these separate identity states, you might have heard them called alters, to hold on to the traumatic memories and just get through the day. And the key thing to remember here is amnesia. These walls between parts create memory gaps, what people call lost time.
All right, now we're getting to the core of the problem, and the source material has this brilliant way of explaining it. Think of it like two incompatible computer operating systems. You've got an app that was built for one system, and you're trying to force it to run on a completely different one. You just know it's going to crash.
And here is that fundamental clash. On one side, you've got the therapist's default software. Let's call it the dysregulation model. It's built for a single mind operating system, right? A single unified consciousness. It sees any kind of distress as basically a behavioral problem. But on the other side, you have the patient's actual operating system, structural dissociation. Theirs is a multi-mind system, and for them, distress isn't just some bad behavior, it's a direct result of that internal fragmented structure. You can see how these two are just never going to work together.
So you might be asking, why do so many clinicians just default to this dysregulation model? Well, honestly, because it's easier. It fits right into the standard therapy playbook they were all trained in. It lets them take these incredibly complex symptoms and cram them into a box they already understand, behavior that just needs to be managed.
This quote from a clinician, this says it all, doesn't it? It perfectly captures that mindset. The fundamental act of switching between alters, the very definition of DID, gets reframed as just a side effect of being emotionally unstable. It's not seen as a structural thing, it's just a symptom, kind of like an extreme mood swing. This is the really crucial part. This model acts like a harmful translator. Amnesia, which is a core neurological symptom, gets translated into, oh, you're just being inconsistent. A protector alter, trying to defend the system, is labeled as combative. A desperate cry for help is dismissed as manipulation. And so the whole goal of therapy shifts. It's not about healing the trauma anymore, it's about stamping out these problem behaviors.
Okay, so now let's flip the script. Let's look at this from the patient's point of view. From the inside, their world isn't a random collection of bad behaviors. No way. It's a highly intricate system, a structure that was built piece by piece for one reason and one reason only: to survive.
And this quote from a patient just cuts right through that whole dysregulation idea. It's a direct rebuttal. It makes it so clear that the alters aren't just a reaction to stress. They are the constant underlying structure of the mind. The system is always there, whether the person is calm, happy, or upset. Always.
Now, to really get why these behavioral approaches fail so spectacularly, the source gives us this fantastic analogy. I want you to picture a restaurant. It has a full staff, but there's no manager, and the communication system between the front counter and the kitchen is completely broken.
And this just illustrates the problem perfectly. So an alter who is fronting during a therapy session agrees to a plan. That's the order being taken at the front counter. But because of those amnesia walls, the broken communication system, that plan, the order ticket, it never makes it to the other alters in the kitchen, the ones who are actually responsible for running daily life. So the plan fails, not because of defiance, not because of a lack of effort. It fails because the message literally never arrived.
So what happens when a therapist tries to force their single-mind software onto this multi-mind operating system? Well, the result isn't just that it doesn't work. It's that it's deeply, profoundly harmful. It creates this vicious cycle of failure and blame.
This right here is what the source calls the DBT trap. Dialectical behavior therapy, or DBT, often uses these diary cards to track things. But for a DID system, the alter who gets that card in therapy might not be the one fronting the next day, or even the next hour. They literally do not know the card exists. So of course, they show up to their next session with a blank card, and what happens? They're labeled non-compliant or resistant. It's an absolutely devastating catch-22. They're punished for having the exact symptoms they came to therapy to get help for.
And believe it or not, it gets even worse. When a patient's very real distress is mislabeled as attention-seeking, Some clinicians will use a tactic called gray rocking. They deliberately show zero emotion, they withhold all empathy, because they believe that showing any human warmth would just reinforce the behavior. Now imagine you're a trauma survivor. That clinical coldness can feel exactly like the emotional neglect you suffered from your original abusers.
This table just lays the tragic disconnect bare. I mean, look at this. A life-threatening fever from a real infection like sepsis is dismissed as exaggeration. A protector alter doing its job is labeled combative. Every single organic symptom of DID gets twisted and reframed as a character flaw. It creates a story that protects the therapist's model, but it completely devastates the patient.
So you have to ask, why? Why does this harmful dynamic keep happening? Why are so many clinicians so resistant to even acknowledging DID? Well, the sources suggest that the answer isn't just about a lack of training. It's about fear.
And this chart is incredibly revealing. I mean, sure, lack of training and professional stigma, those are big factors. But look at that huge slice of the pie. 50%. The single biggest driver is fear of liability. Diagnosing and treating DID is complex, it's high stakes, and frankly, it's just professionally safer for a clinician to pick a more common behavior-based diagnosis.
This quote from the source material is, well, it's chilling. It describes something called defensive charting. This is where a clinician's notes are written not to reflect what's actually happening with the patient, but to protect themselves in their hospital from potential lawsuits. See, if they diagnose a personality disorder instead of DID, the liability shifts. If the treatment fails, it's not the provider's mistake, it's blamed on the patient's noncompliance.
So this brings up a really simple, logical question, right? If a clinician genuinely thinks a patient might be faking DID, the most obvious next step would be to refer them to an expert who's actually trained to tell the difference. But for some reason, that almost never happens. Why is that?
Well, the reason they give is this perfect piece of circular logic. They'll argue that sending the patient to a specialist would just reinforce their supposed delusion. It's the perfect trap. It denies the patient access to the one person who could give them a correct diagnosis, all while letting the therapist stick to their initial, safer, and incorrect assessment.
So, when it's all said and done, when a therapist sees DID through this broken lens of dysregulation, what are the essential parts of healing that just get completely ignored? What is the ultimate cost of running the wrong software? The dysregulation model, it addresses none of the core mechanics of DID. It has no tools for the deep amnesia. It does nothing to help the different parts communicate with each other. It can't map out the system to figure out who the alters are and what their roles are. And most critically, it actively avoids processing the root trauma that created the whole system in the first place. It demands that the patient stop having symptoms before they can get help for what caused them.
And that brings us to this final, incredibly powerful metaphor. Treating DID as just a behavioral problem is like showing up to a house fire, and instead of grabbing a hose, you start criticizing the homeowner for screaming too loud. It completely, totally misses the point. It invalidates the reality, and it leaves them all alone to burn.